All right, 2017 CF 15684, State v. Nelson, back from our recess. Mr. Nonnelly, is the state ready to proceed?
We are, Your Honor.
Ms. Simmons, defense?
Yes, Your
Mr. Nelson, you ready?
Yes, Your Honor.
Doctor, you ready?
Yes, sir.
All right, let's bring in the jury, please. Ms. Simmons, is defense ready to proceed?
Yes,
Mr. Nelson, you ready?
Yes, Your Honor.
Mr. Nonnelly?
Yes, Your Honor.
Doctor, you ready?
Yes, Your Honor.
All right, let's bring them in, please. Mr. Nonnelly, does the state acknowledge the jury?
We do?
Ms. Simmons, defense?
Yes,
Mr. Nelson?
Yes, Your Honor.
All right, Mr. Nonnelly, please continue.
Thank you, Judge.
Now, Doctor, I believe we were talking about switching before we broke. Is that correct?
The design fluency test is what we were speaking of.
Okay, well, let's move on past that. I think we've exhausted that subject. There was another test or subtest called Condition 3 switching, isn't there?
On which subtest of the Dallas-Kaplan? There's a couple. There's one for verbal fluency as well as for...
How about design fluency?
Okay, yes.
And you previously, I believe, said that his design fluency switching score was below the first percentile. Is that accurate?
Yes.
And what was his scaled score attained on Condition 3 switching?
7.
Scaled score is equivalent to what percentile?
16th percentile.
16th or 18th?
16th.
Low average, isn't it?
Yes.
One standard deviation from the mean.
Yes.
Now, you generated, I believe, about 35 separate sub-scores or scores on the Dallas-Kaplan battery, didn't you?
That sounds about correct.
And that's of the part of the Dallas-Kaplan that you administered.
Yes.
And you didn't give all of it.
Yes.
Gave half of it.
Yes.
And you pointed out 2 scores of those 35 scores that are abnormal, haven't you?
I pointed out 2 subtests that showed abnormal executive function
Okay.
testing, yes.
Now, let's assume a perfectly normal, non-brain damaged person. So by chance, how many normal, healthy subjects are going to produce at least 2 abnormal scores?
They're not all the same scores. I have no idea.
I didn't say they were all the same scores, Doctor. I said out of pure chance, how many perfectly normal, healthy subjects would produce at least 2 abnormal scores out of the 35 scores that you produced?
I can't answer that.
You can't answer that.
No, it depends on what scores were irregular.
You're not following my question, Doctor. I'm not saying that there are any particular scores that are irregular. I'm saying that simply by chance, a perfectly normal person is going to produce 1 or more abnormal scores of those 35 tests purely by chance, aren't they?
I suppose so, sure.
But, you're a PhD psychologist, right?
Yes.
And a big part of your training is statistics, isn't it?
Yes.
And but you can't tell me what by chance would be produced, or how many abnormal scores were just produced by chance.
On this particular test?
Yes, sir.
No. I mean, you're assuming each score is the same. And then by the odds, I'm sure we could figure it out. But the odds of getting the scores that were impaired incorrect and the other one's not is very different than just across the board with the same particular test. I mean, you're interpreting the raw data, which is why neuropsychologists have access to the raw data.
You are a neuropsychologist.
Yes.
You are familiar with the data. And you are familiar with the research conducted in your field, aren't you?
Yes, as much as I can be.
And you're familiar with standardized neuropsychological test batteries, aren't you?
Yes,
But you're not familiar with research that indicates 25 to 30% of normal, healthy subjects will produce at least 2 abnormal scores on the test battery, are you?
I'm sorry, what was the ground? Could you read back, Madam Court Reporter, the last question or statement so I can determine if it's a question or a statement?
But you're not familiar with research that indicates 25 to 30% of normal healthy subjects that will produce normal healthy scores on the test of batteries, are you?
Overrule the objection.
I am familiar with that, yes.
You are not.
I am. It doesn't
are.
apply to this particular test.
Okay, but you are familiar with that study, but you just think, your opinion is it doesn't apply here. Is that what you're saying?
That's correct, yes.
Okay, thank you, sir. Doctor, let me ask you this. What is ecological validity?
Ecological validity refers to how these tests relate to day-to-day functions. So, for example, well, I think that's good enough, right?
You made no effort to inquire into the ecological validity of the scores that you generated in the course of your work, did you?
I made no comments about it. I mean, I didn't look at adaptive functions and that sort of thing.
You did not attempt to establish ecological validity for your results, did you?
No.
Doctor, I believe you said that you read Mr. Nelson's statement to law enforcement. Is that correct?
Yes.
You also said that you read a transcript, I believe, of his testimony? Or did you watch his testimony on court TV, or what did you do?
No, I watched a video of his testimony.
Okay. Did you notice anything in the either the transcript or the testimony to suggest that Mr. Nelson was having memory problems?
Well, I can't correlate everything that he said as, I mean, I can't, we can't ensure the veracity of everything that he said, so I'm not sure. I do think in the trial testimony, he was saying he was having memory problems.
But he didn't exhibit those same memory problems in his statement to law enforcement, did he?
Objection, Your Honor, as improper cross-examination and speculation of comment on evidence outside the scope of the secretary.
Overrule the objection to the question.
I don't recall it being the same. I mean, I recall it being a different testimony.
Okay. He gave law enforcement quite a bit of detail during the course of his statement to law enforcement shortly following his arrest, didn't he?
Yes.
Now, Doctor, you said that Mr. Nelson has a documented history of atrial fibrillation, and was shortened to AFib, which is most assuredly much easier to say. Your source of that information, as I understand it, comes from the Bureau of Prisons records. Is that correct?
It comes from his self-report and those records, yes.
That condition has been treated in the Bureau of Prisons, hasn't it?
They were attempting to treat it, it appeared.
Okay. You said that Atrial fibrillation can cause what I believe you described as silent strokes.
Yes.
Do you have any indication as to whether or not Mr. Nelson has actually had a silent stroke?
No.
So there's no way to know what, if any, effect Mr. Nelson's atrial fibrillation may or may not have had on his cognitive function, is there?
That is correct.
If I can have just one moment, Your Honor.
Yes.
No further questions.
Redirect?
And Dr. Will, your scope as far as this case goes was fairly limited, right?
That's correct.
You weren't asked to opine about Mr. Nelson's mental state at the time of the offense.
No, I was not.
And so when you interviewed him back in 2018, you didn't discuss the facts of the crime.
I did not.
And you read the testimony and interview simply to gain background about the case itself.
That's correct, yes.
Now, you mentioned attempting to corroborate some of the self-report that Mr. Nelson gave you with records.
Yes.
There was one car accident that you mentioned when Mr. Nelson was 17,
Yes.
where he described a friend driving drunk, running into a police car, running into an apartment building, being arrested for the DUI,
Yes,
and Mr. Nelson being a passenger
that's correct, yes.
and hitting his head.
Yes.
And you were provided with a police report of that incident.
Yes.
And so that incident was at least partially corroborated without, obviously medical records would have been nice to have, right?
It always is. It's often not possible, but it was partially corroborated.
Even if we had medical records, can you tell us about the 1970s and our understanding of concussions as far as what would have been done back then versus now?
Objection, irrelevant.
I'll overrule the objection.
Well, certainly, we don't have the imaging technology. We don't have the understanding of even how mild head injury has an effect. So the technology for care and treatment and our sensitivity that we have now, obviously, to doing in the very least, a preventative evaluation was non-existent.
So you mentioned your work with the NFL. Do you believe that our understanding of head injuries has greatly increased from the 1970s?
Yes,
Okay.
I would hope so.
Okay. And then as far as other corroborating evidence, you were given a transcript of James Nelson's deposition
Yes,
where there was a discussion of the car accident that Mr. Nelson was in as an 8-year-old.
that is correct, yes.
Okay. And then there was further documentation of head injuries, as you mentioned on when we first spoke, regarding head injuries in prison, falling from his bunk, being assaulted by other inmates, head banging, self-injurious behavior. That was all in the records.
Yes, it was.
And so there were areas of Mr. Nelson's self-report that were corroborated by independent evidence.
Yes.
I want to talk a little bit about the malingering tests. So those have been studied and normed and researched before being put out as measures for you to use.
Yes.
And they're designed so that the subject doesn't know which tests are for malingering.
Yes, that's an important descriptor that I left out. Yes, that's absolutely true.
Okay.
Many of them look like memory tests that I'm giving to them.
So is it easy to tell which is which? when you're testing for malingering versus memory or language?
Not unless you've been coached. It's not. No, it's not. And there's plenty of research to support that.
Okay. And you mentioned that there are some standalone tests that test for malingering and some questions or measures within executive functioning tests or language tests that are designed to test for malingering at the same time.
Yes, we describe those as embedded measures.
Okay. Now, when you're giving these tests, you're not telling the subject what the test is called or what it's for, is that right?
Absolutely.
And so in order to somehow cheat the system and malinger and score poorly, is it fair to say that the subject would have to know which question was which, do well on malingering tests, and then purposely fail on the substantive testing?
Yes, absolutely. And it should be noted that the malingering measures are administered throughout the testing session because they're also symptom validity. If somebody is, for whatever reason, not paying attention, we also want to make sure that that's not causing the problems that we've talked about. So they're administered throughout the testing session to ensure to have a check that one is giving their full effort,
Okay. And
not
these,
cheating the system, as you said.
okay. And so these malingering tests are used across clinical and forensic psychology.
Yes.
They would be a part of any evaluation?
Yes, I mean, as the state had highlighted, more important in forensic cases. We just know that in the medical legal realm. So the focus is certainly higher on those particular tests in those situations.
Okay. And in this case, you had no evidence that Mr. Nelson was malingering or trying to cheat the system in some way or not giving his full effort?
Not on my testing, no.
Okay. And the state asked about antisocial personality disorder. Now, you're a neuropsychologist, right?
Yes.
You're not diagnosing personality disorders, bipolar, depression, things like. I'm sorry, I lost my question. You're not doing evaluations to diagnose personality disorders or psychological diagnoses.
Not in this case, no. We were looking at central nervous system
Okay.
dysfunction.
So you didn't rely on those parts of the records in coming to your conclusion in Mr. Nelson's case?
No.
And the diagnosis in the records included bipolar disorder, depression, antisocial personality disorder, right?
Yes.
Does that affect his cognitive deficits or your opinion on your portion of the evaluation of Mr. Nelson?
It can, but in this case, I don't believe that it did.
Okay. Now, antisocial personality disorder would require specific testing, is that right?
Responsibly, yes.
Okay. In the records, there were no test results or raw data.
Not that I remember seeing. I don't think there was any testing that, objective testing that was done to support that diagnosis.
And there was no information on who had diagnosed him with that?
Not that I recall.
So you don't know how that diagnosis was arrived at or what was done?
As far as I saw, it was just a label that was presented. I didn't see any supporting, any excerpts in the medical records supporting the diagnostic impression.
Okay. You talked about silent strokes and that you don't have any evidence in this case specifically that was what was happening.
Yes, that's correct.
What else would you need to figure that out?
Certainly a neurologic exam and imaging would be the gold standard, would be imaging. to see how the cerebrovascular system has changed.
And is that why you recommended a neurologist and further brain imaging studies or further testing?
Yes.
Okay. You mentioned on direct that it's important that only qualified and trained individuals have the raw data,
Yes,
and that there's a risk that someone can distort the data.
that is correct, yes.
So I want to talk about this, I guess, the total test score versus subtests. You mentioned on cross-examination that some of the total scores, the average was in the average or above average range.
Yes,
And these total scores are made up by subtests in different areas.
that's correct.
So you mentioned that he did very well in language.
In many of the language tests, except for there was some problems when you throw frontal lobe executive functions into it, then he had a problem.
Okay. So when you said on cross-examination, that's not an executive functioning test, can you explain a little bit more about what that means as far as what the state was trying to point out as a total score?
Sure. So let's go to the design fluency task, which was asked about. So you're asked to connect dots, solid dots, in a minute. Then you're asked to connect unfilled dots. Then that's not an executive function task, okay? That's almost a speed of processing task, visual scanning. He does very well at those. That's a part of the Dulles-Kaplan executive function system. But the executive function task, the frontal lobe task, is now what I want you to do is switch back and forth between solid and non-filled circles. So you have to switch sets. People that have frontal lobe problems will get stuck. They'll go from what they were doing before, either solid to solid or non-filled to non-filled, and not be able to switch back and forth, not have the mental flexibility relative to your IQ and other factors. That's where it was abysmal. That's where he had problems, which was not something that was brought up in cross-examination. That is the true measure on that particular subtest of executive functions.
Okay.
So we were just talking in cross-examination about scores that were relevant, but not at the core of what the deficits were.
Okay, so Mr. Nelson's scores were highly divergent in different areas. Is that fair?
Well, again, I mean, they were, but there was a general pattern where there was deficiencies.
I guess I should say divergent in different areas or different skills of testing?
Sure. I mean, we all have our strengths and weaknesses, obviously, and you know, some of the language skills were definitely more developed.
Okay, so I think you mentioned one language skills test where he had scored in the 76th percentile, something like that?
Probably.
Okay,
I'd have
just
to-
as an example, there
Okay.
were some where he was above average, is that right?
Yes. Oh, yes.
But then his executive functioning and memory testing were down at the first percentile.
Some of it was, yes, and it's not by chance, in my opinion.
Okay, and so when you average those together, it can mask deficits in certain areas, is that right?
I mean, if we take all of the scores and, yes, that's not what we do.
Okay. So in Mr. Nelson's case, the subtests are really important based on what area they're testing.
Absolutely.
And each subtest would have its own normed scale.
Well, they're all normed on the same standard scores of 10 as average,
Okay.
and so on. As we-
May I have 1 moment, Your Honor?
Yes.
And so, just to clarify, can you tell us which areas Mr. Nelson scored poorly?
In general,
In general.
so in general, in summation, he had a lower IQ than what would be expected. He showed some executive function deficits that would not be expected, as well as some deficits on memory testing that were not expected.
I don't have any other questions, Judge.
All right, doctor, you can step down.
Thank you, Your Honor.
Ms. Simmons, please call the next witness for the defense.
Judge, may we approach first, please?
Pardon?
May we approach before? the-
Yes.
That's fine.
All right, Ms. Simmons, please call the next witness for the defense.
Yes, Your Honor. We will call Dr. Rubino.
Thank you.
For the testimony you're about to give, will be the truth, the whole truth, nothing but the truth, so help you God.
Sir, please state and spell your first and last name for Madam Court Reporter.
Mark Rubino, M-A-R-K, Rubino, R-U-B as in boy, I-N-O.
Thank you. Ms. Simmons.
Thank you, Your Honor. Good afternoon, Dr. Rubino.
Good afternoon.
Can you tell us, you're a medical doctor, correct?
Yes, I am.
Can you briefly tell us your specialty?
I'm a neurologist.
And can you take us through your education and training background?
After obtaining a 4-year degree, I got my Bachelor of Science in what's called Integrated Life Sciences. It's a pre-med degree. And then I did 4 years of medical school, getting my medical degree. And then I did a transitional residency in Summa Health Systems, Akron, Ohio, mostly at St. Thomas Hospital and Akron City. And then I moved to Florida, in which I did my neurology residency at USF in Tampa. And then I went to work.
And are you board certified?
I am.
Can you tell us about that, please?
Once you complete a residency, you become board eligible. And then the goal is to become board certified, which is, in neurology, a certification process that takes the form of a written test as well as an oral examination, at least on the first time. On retries, it's just doing a certain amount of continuing medical education and then passing a written test.
You might need to speak a little louder. I'm having trouble
and-
hearing you.
And passing a written test after that, after you do all your requirements.
Okay. And when did you become board certified?
Initially in 2001
And that's in neurology?
in neurology.
Okay. And so you specialize in head, neck, and back injuries?
Yes, I do a lot of injury work, head injuries, neck injuries, back injuries. Also a lot of just general neurology, such as Alzheimer's disease, Parkinson's disease, stroke, migraine, movement disorders, that's Parkinson's, Huntington's, balance problems, peripheral neuropathy.
Okay. And you have a general neurology practice?
I have a general neurology practice, yes.
And that's in Naples?
Yes, in Naples.
And would you say about 10% of your work is done on a consultant basis for civil and criminal cases? Or can you tell me about how much of your...
The question was, I heard it before, is that how much my income is. And it's actually less than 10%.
Okay.
Of my time, it's more intrusive.
Okay, so, but the bulk of your work,
It's clinical practice.
okay. And have you testified as an expert in court, either civil or criminal, before?
Yes, I have.
Do you know how many times?
Over the course of my career, I can't really count, but it's been several times. I can tell you in the last year, I've had 5 of these trials.
Okay.
As a matter of fact, last year.
Okay. So, and in this case, you were brought in and you reviewed some records, is that right?
That's correct.
and you did some of your own testing. And so I want to go through them one at a time.
Okay.
So you did an evaluation of Mr. Nelson in September of 2018, is that right?
That's correct.
Can you tell us about that evaluation, what it includes?
Generally, what I do as a neurologist, being a clinician, I'll take a history. I'm a doctor. So I'll take an extensive history, asking about his medical conditions, but I'm particularly interested in head injuries and other factors that may affect one's brain. So after I take a history, then I'll do a physical examination, which includes a neurological examination.
So do you do physical testing, but also like a questionnaire type testing?
Well, the physical examination has a mental status examination, and so a neurological examination has parts to it: mental status, cranial nerves, motor, sensory, deep tendon reflexes, coordination, and gait.
So can you give us an idea of what you're actually doing during this evaluation?
I'm assessing him. I'm basically, that's what I do. I figure things out. I'm a neurologist.
And so does that include verbal questioning, but also some kind of physical?
You take your history, which would be what's called subjective, and you do examination, what's considered objective, because that's something you can see.
Okay. And so with Mr. Nelson, can you talk to us about the evaluation that you did on him?
His neurological examination is what we're talking about, correct? Okay.
Yes.
The first thing part of his examination I did was called a Montreal Cognitive Assessment. It's like it's sort of like a neurological test that neurologists do. I'm not a neuropsychologist. I don't do this type of extensive testing as a neuropsychologist, but I get an idea of where the deficits are. His MoCA, that's short for Montreal Cognitive Assessment, was impaired at 24 out of 50.
Can you tell us what the scoring on that test means as far as where the deficits are?
Well, you can break it down to see where the deficits are. Let me let you go. He had problems with naming pictures of animals. For example, a lion, he named a tiger, and a rhinoceros, he named a hippo. Camel, he got. And then he had some deficits in attention and short-term memory loss.
Okay. And with short-term memory loss, I mean, there are different types of memory, correct?
Yes, there's long-term memory, short-term memory, and different memories will have different impacts.
So is it possible or common for someone to have problems or issues with short-term memory but be able to recall dates and specifics from a long time ago?
Yes, that's why I clarified short-term memory.
Okay. And so he has an issue with just short-term memory.
Yes.
Now, you talked about taking a medical history, and there was a history of head injuries that you discussed with Mr. Nelson?
He had several head injuries that they told me about. The first time I remembered was he was hitting the head with a vacuum. He needed some stitches, but couldn't tell me much because he was a little kid. When he was 9 years old, he was riding his bike, and a car had brushed up with him, but the mirror had hit him, knocked him off his bike, and knocked him out unconscious. He ended up in the hospital sometime in 1973. Spent a day in the hospital, but beyond that, we don't know much more. The following year, somehow someone was swinging a beer bottle by a string and swung it around, hit him in the head. His father butterflied it.
I'm sorry, he got butterfly?
His father butterflied the wound.
Okay.
That's just one of the questions I always ask is, when you have injuries like that, did you notice anything happen in school? Like grades get worse or anything like that? And he did say his grades in sixth grade went down. Is there any reason? Were you drinking? Were you smoking? It's like, no, I wasn't doing any of that stuff. And then, so now he got punched in the head. In 1981, he was in a car accident. A drunk friend of his went down the wrong road and crashed into a police car. He was the unrestrained passenger. He said he had his head on the dash, but could not tell me much more than that. Frequently, you have concussions, you don't remember much of the concussion. But then he had a bunch of other ones. He was in a series of motor vehicle accidents in the mid-'80s. He had worked at a car dealership and made a habit, or not a habit, but he did it frequently, of basically getting drunk and crashing the cars. It's almost like when someone's addicted to alcohol, they have no regard for their own safety. They have no regard for their own head. And he banged, he's never wearing a seatbelt, and he crashed those cars hard. There's one in 85, or 84, 85, 86. Then another source of head injury was when he was about 16, he started banging his head. And banging his head was, he'd basically bang his head even then and when he was in federal prison. He was known to bang his head. That's not normal.
Okay, so this history of head injuries, did it affect what testing that you performed on Mr. Nelson?
What the MoCA could pick up on would be the short-term memory loss, the inattention, and one of the things I noticed when he was doing the test was impulsiveness. I think one of the reasons why he had loss of attention is very impulsive. He would name something really quickly without even thinking about it.
Okay, and then you went on, you said there were other parts of the neurological examination regarding motor strength and tone and sensory coordination. Can you take us through that part of your examination?
Well, the next part of the neurological examination is assessing cranial nerves.
I'm sorry,
Assessing cranial nerves.
cranial nerves?
Basically, the cranial nerves are the nerves that arise, that innervate your head. Cranial nerve 1 is your ophthalmic nerve. Or as olfactory bulb. It's olfactory. Cranial nerve 2 is optic. I didn't test olfactory because I didn't have anything to smell. I have a hard enough to get my equipment in the jails as it is, but that's one of those things that's hard to get. But I test his visual fields, and he has a right lateral visual field deficit, in that he couldn't see the confrontation on his far right side. The remainder of the cranial nerves were normal, except for the oculomotor movement, in which he had something called loss of smooth pursuit. When a doctor's testing your eyes, making you like look to the left, look to the right, look up and down, it should flow very smooth. But his became very just jerky. You get that just from loss of appropriate coordination of the eyeballs, from basically injury to the brain of some sort. Then he had a little right arm weakness.
Actually, doctor, can I ask you a question about the extraocular movements? What do those results tell you?
Your eye movements are controlled by what's called oculomotor nuclei. They're the cell bodies to the nerves that generate that go to the muscle that control the eyes. 3, 4, and 6. Those are the cranial nerves. But those cell bodies get innervation from your motor cortex through your basal ganglia so it can be modulated and made uniform and before it gets to the eyes. If a lot of stuff happens in that pathway on both sides, one loses smooth pursuit. It becomes much more jerky.
Okay. So when you're looking at these movements and you're not seeing smooth pursuit, it's showing you that there's a disruption in the information from the brain cells to the nerve?
From the cortex to the midbrain.
Okay. And could that be due to brain injury or some sort of vascular disease?
That could be either due to brain injury or vascular disease, yes.
Is there a way to differentiate between the two or to figure out a cause?
Not without imaging.
Okay.
I can see as deficits. I can have an opinion depending on what risk factors I have, but with both vascular risk factors and head injuries, I don't know which is causing which.
Okay. I'm going to come back to that.
Okay.
You started to talk about, you mentioned the right visual field cut, and is that what it sounds like? Like he's got an issue with seeing past a certain point?
If something approaches him from the far right lateral, he will not see it.
Okay. And what is that evidence of to you?
That is left occipital lobe injury, and that's usually from stroke. And I had a realization as I was sitting out there that on the MOCA, when he named those animals wrong, that is in the brain very close to where the right field deficit comes from. It's from the left occipital lobe. Visual association cortex is right next to it. So he might be able to see it, but he couldn't give me, he gave me errors on what it's called.
Okay, so that,
This is just a larger stroke in the left posterior brain.
and then I think you were starting to get to his reflexes and strength testing, or did I skip something?
Well, he had right arm weakness,
Okay.
and arm weakness too is likely from stroke. This is all on the right side, and the most likely reason is because he had atrial fibrillation. And atrial fibrillation is a condition which, unless you're on Coumadin or blood thinner, tends to churn up clots that go to your brain. They have a tendency to go to the left because that's the straight shot. To go to the right, they have to kind of go, it's a little more tortuous, but the straight shot from the aorta down into the brain is the left internal carotid artery to the left MCA and left PCA.
Okay, and Mr. Nelson had reported atrial fibrillation to you, but it was also in the records?
He developed it after his, when he was in the hospital for the ruptured diverticula. And he got the colostomy.
Okay, so you're referencing when he was taken out of federal prison for a surgery, they recognized the atrial fibrillation?
He was in the hospital, yes.
Okay. And you were talking about weakness, diminished deep tendon reflex. If you could go back to the physical.
Right. He had decreased reflexes and decreased distal sensation, the temperature and vibration. That is very typical. It's called a peripheral neuropathy or polyneuropathy. Most common cause of polyneuropathy in the U.S. is diabetes. I don't think he's diabetic. Second most common cause is alcohol abuse.
Okay.
And I think that was probably the most likely cause of it.
Okay. Now, you mentioned that some of these symptoms can be caused either by injury, like a head injury, or by vascular disease.
Yes.
And in the medical history interview and also in the records, you saw evidence of both.
Correct.
And so you mentioned that there's no real way to know what is causing his symptoms without imaging studies?
The visual field cut the right arm weakness, and maybe the visual, what's called agnosia, where you can't understand what you're seeing, is likely stroke. The loss of smooth pursuit is either from brain injury or something you can also get from mini strokes. If he was a smoker as well, and that causes these tiny little strokes in the deep white matter of the brain, and that can do the same thing. Basically causing disconnections within the brain.
Okay. You're not talking about the stroke that we're used to like actually seeing effects of physically on someone. Like, these are smaller, maybe less noticeable.
Yeah, these aren't big strokes. I mean, he didn't have the left MCA, or a left MCA stroke is like the worst stroke in my opinion, where you block off the big artery, you lose your speech, you lose your ability to use your right arm. Speech being you can't express yourself and you can't understand anything being said to you. He didn't have anything like that. He had events that get missed because if your arm's a little weak, no one really pays attention to it. If your field gets cut a little bit, no one's going to pay attention to it because you don't notice it. There's this thing called silent stroke. And he had a lot of silent strokes. At least 3 I can tell.
And he has risk factors in his background for that.
Hypertension, smoking, alcohol abuse. I mean, he's 52 years old, he developed atrial fibrillation. That comes from vascular risk factors. Typically uncontrolled hypertension, where the atria gets dilated and starts causing atrial fibrillation.
Okay, and we don't know how long he was living with atrial fibrillation without treatment. Is that fair?
Correct.
Okay. And then once there is some evidence that he was on Coumadin.
Yeah, when he was in the hospital, when they released him, they put him on Coumadin, and then the jails, the BOP, the Bureau of Prisons, maintained him on Coumadin.
Okay. Now, once he was released and homeless.
I don't see how he could have stayed on Coumadin because Coumadin is a drug that it's known as rat poison, but it basically thins your blood out. The more you take, the more thin. Unless you get your blood monitored, no one's going to give you Coumadin because they don't want to kill you. So I don't see how he could have been on Coumadin once he got out of federal prison.
Okay. And not being on Coumadin when you need it could lead to these silent strokes.
Those cortical strokes, the strokes that they could have happened then.
Okay. Now, you didn't have any medical records from the 70s with these car accidents, right?
I did not have any medical records from then because you don't have to keep medical records beyond 7 years.
Do you think that those records would have even been helpful given how far, I guess, our knowledge of head injuries has come since the 70s?
And so they didn't have MRI. CAT scan was very rudimentary in 73. And not been very helpful because brain injury, unless it was a skull fracture, brain hanging out of your head type of thing, would get someone's attention. But a mild traumatic brain injury was not even a term in 1973.
Can you tell us a little bit about the difference between treatment of concussions in the 70s versus now? Or head injuries more generally?
Treatment's not much different because not a whole lot you can do besides brain rest. But we do brain rest. Now in high school athletics, you have a concussion, to run a protocol, then you need to sit out a few games until you recover from it. In the past, you have a concussion, they put you right back in the game. most of this damage that occurs in people with concussions is they have one concussion, then they have another concussion soon thereafter, and it's even more damaging because the brain's still recovering from the first concussion. Then you hit with a second, it doesn't have any power to recover from it, and then you have more damage occurring.
Now, in this case, after your evaluation, well, let me just ask you to summarize your physical examination, your neurological examination. What did that indicate to you as far as deficits of Mr. Nelson?
He had multiple deficits, including cognitive deficits, cranial nerve deficits, motor deficits, deep and reflex deficits, and sensory deficits. I mean, he had multiple deficits.
Okay. And you mentioned that to figure out the cause of that, you would need imaging.
To figure out the cause of the mental status and the motor deficits, I would need imaging, and especially differentiate between vascular disease and any other causes.
Okay. And so what was your next step after the evaluation, Mr. Nelson?
Doing MRI of the brain and a CT PET. MRI of the brain would be helpful at elucidating stroke versus anything else, whereas the PET scan would be more helpful at seeing with the non-stroke brain how metabolically active it was, which would be suggestive of brain injury or not.
Okay. And so did you actually write a prescription for these imagings?
I did.
And did you get imaging done?
I did not.
Can you tell us why?
When I was told, he refused.
Okay. And so in the history, the records, and all of that, there are multiple possible causes of these deficits?
In the brain, there's basically two categories, vascular and traumatic.
Mm-hmm. But in Mr. Nelson, these deficits could be caused by brain damage from head injuries,
Yes,
or stroke,
yes.
or atrial fibrillation
Atrial fibrillation will cause brain damage by stroke.
by stroke. Okay. Vascular disease,
That's vascular disease.
alcohol abuse.
Alcohol abuse, to some degree.
Okay. And you mentioned a long list of head injuries that could have contributed or combined to result in deficits.
Yes, especially the number of them. He had a lot of concussions in the 80s. The behavior probably changed after he got hit by a car when he was 9 years old.
And so the effects of these deficits and injuries, you mentioned, leads to impulsiveness.
Brain injury typically causes impulsiveness, loss of appreciation of right or wrong, or impaired. Planning is impaired. Not necessarily that they can't plan. It's just when you're planning, you're not thinking of all the potential problems along your plan because you're impulsive and you're not processing right or wrong as you're going through your planning.
I want to ask you about impulsivity because, I think we tend to think of impulsivity as something immediate. Is it possible to be impulsive over a longer period than just a moment, over a period of days, or do something that's impulsive that doesn't seem impulsive the way I, as a layperson, might think?
Someone who's impulsive tends to have impulsive traits. When they're put in a more stressful situation, that may drive up the amount of impulsivity.
Okay. And you mentioned lack of Not necessarily a lack of planning abilities, but poor planning?
Poor planning.
Okay. Did you see evidence of that with Mr. Nelson, I guess in the records? We've talked before, you mentioned his surgery that required a temporary
yeah.
colostomy. Were you were given those records?
Yes, the Bureau of Prisons, after his colostomy, he was due to have his colostomy taken down and basically made back into a normal person again, not with a colostomy bag. But somehow it got pushed back to after his release date by, I think it was like a month or so, which meant he would have to stay in prison for a month so he could have the surgery and then be released. Well, he didn't prison so much, he didn't care, he just got out of there, even though it was a bad decision to go out into the world without any medical insurance with a colostomy bag.
And from what you've seen, do you believe that Mr. Nelson has an impaired frontal lobe?
Yes,
And that would affect his executive functioning?
yes, it does. Decision-making,
And his decision-making and impulsivity?
correct.
May I have one moment, Your Honor?
Yes.
You mentioned you're a medical doctor,
Yes,
so you weren't brought into this case to make any kind of psychological diagnosis.
correct. I'm a neurologist.
And you weren't asked to opine about Mr. Nelson's mental state at the time of the crime.
Correct.
And so you never interviewed him about what happened in this case.
I did not.
You were just,
I'm just evaluating his brain.
okay. I have nothing further, Judge. Thank you.
Cross-examination?
Good afternoon, Doctor.
Good afternoon.
You said in connection with your discussion of poor planning that Mr. Nelson made the decision not to have his colostomy reversed because he wanted to be released from prison so badly. Is that your understanding of what happened?
Yes,
You reviewed the Bureau of Prisons records, did you not?
I did.
And in fact, the Bureau of Prisons records reflect that Mr. Nelson was given the choice of remaining at the institution and foregoing placement in a halfway house in order to get the colostomy reversed, don't you?
Well, in order he could stay, the halfway house, does ring a bell now.
You don't remember that part of it?
No, I read the full, it's 800 pages I read in September.
So you don't remember that part of it?
The halfway house, I don't know what happened in the halfway house.
I'm sorry, sir?
I don't know what happened, why he didn't go to the halfway house to get it done.
You think he did not go to the halfway house?
He didn't have it reversed. It's
Well, that's
never-
not my question. I mean, he could have stayed in the institution and not gone to the halfway house.
Yes, he could
Had
have.
the colostomy reversed, couldn't he?
Yes,
But he chose to go to the halfway house instead.
correct.
Now, and you think that's poor planning based by him?
Yes, I think it is.
But he didn't just like walk out of the gate of the prison and be a free man, did he?
He wasn't a free man, he was under probation.
Now, doctor, the one thing, or maybe the two things that you really need to make final opinions and conclusions about Mr. Nelson are the two things that you don't have, aren't they?
Correct,
And that would be a PET scan and an MRI.
correct.
And your understanding is that Mr. Nelson refused to have those procedures done.
Yes,
So without those procedures, you're basically very, very limited in what you can offer this jury, aren't you?
Well, as a neurologist, I can tell you that he has these deficits, and the most two likely reasons for them happening are these two reasons. I can't tell you which is which because I don't have those scans, but I am a neurologist and I'm trained to evaluate this sort of thing.
And your evaluation is based on,
Yes? All right, members of the jury, in this moment, we're going to take a brief recess. During the recess, you are going to continue to leave your notepads and your pens here. During the recess, you're under all the court's instructions, including but not limited to the instruction not to discuss this case amongst yourselves with anyone else. Please follow the deputy in the jury room. We'll bring you back as quickly as we can. Thank you. Doctor, if you need to use the facility, you can do that if you'd like. Mr. Nunnally, is the state ready to proceed?
you are, Judge.
Ms. Simmons, defense?
Yes, Your Honor.
Mr. Nelson, you ready?
Yes, sir, Your Honor.
Doctor, you ready?
Yes.
All right, let's bring in the jury, please. Mr. Nunnally, does the state acknowledge the jury?
We do, Judge.
Simmons, defense? Mr. Nelson?
Yes, sir, Your Honor.
All right, Mr. Nunnally, please continue.
Doctor, I apologize if I'm repeating myself here. Is it fair to say that your work in this case has been severely hampered by the lack of imaging studies?
It's been limited. It's much more interesting when I have the studies.
And by imaging studies, just so the record is clear, we're talking about either PET scans or MRI scans or both.
Or both.
Now, and because you don't have those scans of Mr. Nelson's brain, your opinions are based essentially on symptoms that could be caused by a variety of things, aren't they?
I wouldn't say a variety of things. There's probabilities. Like I have experience. I am a neurologist, and there were neurologists before there was MRI and CT. But to answer your question, I can't differentiate between vascular disease, traumatic brain injury, or something else that I can't foresee.
And you're also, at least to some degree, including risk factors within your opinion base. In other words, I think you said the fact that he was a smoker and the fact you said he was an abuser of alcohol. Those are risk factors, aren't they?
Those are risk factors, correct?
But that doesn't mean that he has in fact suffered from something as a result of those risk factors, does it?
How much of his deficits are caused by which factor, I do not know.
Was there any description by Mr. Nelson of symptoms following any of these head injuries that you have identified?
Well, I would ask him if he had certain symptoms. He would say yes.
You would ask him if he what, sir?
If he felt dazed, he felt confused, he felt disoriented. He said, let's see when. When he got punched in the head in 79, when he was 15, he had basically, he was dazed and confused, went to the hospital after that.
And how long did he stay in the hospital, sir?
Then he just went in and went out. It wasn't a long stay.
Was this from the bicycle accident or from something else?
He got punched when he was 15. There's no records of it. This is just
This is what
self-reported.
Mr. Nelson told you.
Yes.
And I believe you said that the information that you had was that he stayed overnight following the bicycle accident when he was 8 or 9?
When he was 9 years old, he spent the day in the hospital. I assume that's one day, but I have no medical records. I have nothing to base on how long he was in there.
Did he report any residual effects from any of these head injuries to you?
Only that when I asked him how his grades were in school, and his grades dropped around 6th grade.
Could that be equally explained by some other factors that didn't enter into your work in this case?
A lot of times it was drug abuse or something like that, but he denied having any kind of alcohol or drug abuse at that age. I know his dad was a workaholic. I don't think there was any issues there. Like family issues can cause the same thing. But having your head banged a couple times can make you not so sharp in school anymore.
Did you actually see any 6th grade records?
I had no school records. This is also self-reported, but 6th grade seems to be a good timing for a couple of these head injuries.
So you have no independent corroboration aside from what Mr. Nelson tells you of these incidents, do you?
I have no corroborating evidence. I do not, correct.
Now, doctor, let me ask you this. Did you have the opportunity to review Mr. Nelson's statement that he gave to law enforcement?
I have not. I have not received it, and I have not reviewed it.
You mentioned that he had some short-term memory deficits. How short-term are we talking about? How short-term are we talking about?
It's remembering 5 words for about 10 minutes.
Okay. And what are those words? What words did you ask him to remember?
Church, daisy, red, velvet, and face.
And I'm going to guess you use those same words every time, don't you?
That's on the mocha.
Okay.
My practice, I use 3, black shoe and charity.
I'm sorry?
Shoe and charity.
Okay, so, and there's a reason you use the same 3 words every time, isn't there?
So I remember them.
Exactly.
The benefit of an Alzheimer's patient, you can use them every day.
Excuse me, sir?
The benefit of an Alzheimer's patient, you can use the same 3 words every time.
And you can't really distinguish based upon any of the information that you have, given the lack of the imaging from the PET or the MRI scans, what may have caused any of these identified deficits that you've talked about. Can you?
I think if you ask 100 neurologists what would cause a visual field deficit, a visual agnosia, that's not being able to identify an object when you see it, as well as right arm weakness, in a gentleman with atrial fibrillation, 99% of people can say stroke.
Did you do anything in the course of your work in this case to determine whether or not Mr. Nelson was malingering on the MoCA, which is what, Montreal Cognitive Assessment?
Malingering is going to be a limitation of the MoCA because there's no built-in malingering issues. The only one you could really malinger good at is be the short-term memory. But most of the time, people have pride in what they do, and they try to do the best they can because they don't really realize what I'm doing.
But this is a forensic evaluation that you're conducting, isn't it?
It is.
And by forensic, I mean an evaluation conducted by you as a medical professional for use in a criminal prosecution.
Correct. But,
And because Mr. Nelson is facing the death penalty, he certainly has an interest in the outcome of your evaluation, doesn't he?
He does have an interest.
And you said, Doctor, that some of the behavioral correlates that you might see in connection with his condition are impulsiveness, inattention, and poor planning. Those would be some of the things that the condition you have described may cause, aren't they?
That's particularly frontal lobe injury.
Okay.
And that's something you would see from traumatic brain injury, yes.
Are such behaviors as impulsiveness, poor planning, and inattention, I believe, consistent or inconsistent with any other psychological or psychiatric diagnosis that you are familiar with?
I'm not a psychiatrist, so I'm not going to opine on the question, other than even people with those diseases have altered function of that part of the brain. It's just how we describe it.
And doctor, you said that you did not believe that he was being treated for atrial fibrillation following his release from the Bureau of Prisons. Did you ask him about that, or is that just your belief based upon what you know about the medication that is used?
Actually, I thought of that after I saw him and had not talked to him again. So I couldn't have asked him whether he was on Coumadin at that time.
So you don't know if he was on Coumadin
I
after
don't know
release
for
or not?
I don't know for sure.
Okay. So he may have been, for all you know,
I highly doubt it, but yes, he might have been.
but he may have been. You just don't know one way or the other.
I'd be shocked if he was maintaining medication when he was out.
Do you know what he was doing in Orlando between the time he was released and the time he was arrested for the murder of Jennifer Fulford?
He had been working for a painter of some sort, or that's all I know.
Do you know what kind of work he was doing?
It's something in the painting business.
Do you know what other kind of jobs he's held over time?
Well, I worked in a car dealership. He worked in a lot of dealerships. I don't have any other job though.
Well, doctor, and just a couple more questions. In medical practice today, it's standard to use either an MRI or a PET, I believe, in making a diagnosis of a concussion. Is that fairly accurate?
In my clinical practice, when I do a concussion, concussions are diagnosed clinically. I mean, you hit your head, you have some kind of symptom afterwards. You have vertigo, you have a headache, you have some short-term memory loss, or you just have difficulty learning new tasks, some kind of cognitive impairment from a concussion. That's a clinical diagnosis. Frequently, a plain old MRI is going to be normal.
Okay.
So we'll do a plain old MRI if people have a concussion. But if it's a car accident or other litigious type process, somehow we come up with a better test to prove it, whether it was present or not, because there's secondary gain.
And what is secondary gain?
Secondary gain is basically saying you have something when you really don't, but you could, but you amplify or magnify your symptoms in order to get a bigger payout, either financially or some other reward.
And you did nothing to incorporate an assessment of Mr. Nelson's desire for this secondary gain in your evaluation, did you?
Well, the MRI ordered was with DTI. DTI is what's called diffusion tensor imaging, which is basically a very objective measure of brain injury because it examines the axonal pathways, and if they're disrupted in a certain section, we can surmise that damage happened to the brain because of traction on the brain. When it hits, the hemispheres move at different rates, and you have what's called shear injury. That kind of stuff we can see on DTI. We can't see it on plain MRI unless it's severe with bleeding. Then we can see it on MRI, but typically we need DTI.
So you would have been able to assess secondary gain but for Mr. Nelson's refusal to submit to the necessary testing, wouldn't you?
I don't have the test.
So the answer is yes, isn't it?
Yes.
No further questions.
Redirect.
Doctor, the testing that you were able to do showed clear deficits, right?
Yes.
And you reviewed testing by other doctors that also showed clear deficits.
I reviewed Dr. Woe's records, which did have validity testing built into it.
Meaning malingering testing.
Malingering testing, basically whether the test is valid or not.
Okay. So the testing that you and other doctors did showed clear deficits.
Yes,
And so the symptoms are clearly there.
without a doubt.
And the only thing that the imaging would tell you was the cause.
Yes.
Okay. And so these cognitive deficits are real.
He has cognitive impairment, yes.
Thank you. The imaging doesn't really go to that. It goes to the reason why.
Yes. In neurology, we're trained to first establish what the problem is. Then the next avenue is, where is the problem localized to? That's why I kind of point to the left hemisphere. That's why you may hear that strangeness about how neurologists talk, is because we're trying to localize. And once we get localized, then we go to etiology. What caused this to be here? And can we tell from the localization of what's the most likely cause of that problem? That's why the visual field cut is going to be stroke, because it's down the pathway from the atrial fibrillation.
Okay, so the testing doesn't, the imaging doesn't change your opinion that Mr. Nelson has cognitive impairment or dysfunction, however you worded it.
His cognitive impairment, based on Dr. Woe's testing, my testing, Dr. Wood's testing.
And you just can't say with certainty what the cause of that is. You have options that he has a history for.
He has a significant history for head injury. He has a significant history for stroke. I think he has both of them. I just can't tell you how much of each he has.
Okay. And when talking about malingering, well, you mentioned that there was the deficits on different types of testing were localized.
Yes, even on the MOCA, they were local. They were specific tests. There were specific things that he was wrong on, and other things he did great on.
Okay, and the things that he did poorly on or got incorrectly on the physical testing and the MOCA were all localized the same area of the brain?
The short-term memory loss that could be from brain injury or from multiple strokes. The naming issue, I suspect, is due to the same thing that caused the visual field cut, because they're right next to each other on the left side of the occipital lobe. They localize to the same area, must be the same etiology for what caused it.
Okay, and so in order to, I guess, fake those results, one would have to have a significant knowledge of neurology?
He would have to need to be a neurologist.
I don't have any other questions, Judge.
All right, doctor, you can step down. Thank you. All right, members of the jury, in just a moment, we're going to take a brief recess. During the recess, you're going to leave your notepads and your pens here. During the recess, you're under all the court's instructions, including but not limited to the instruction not to discuss this case amongst yourselves with anyone else. Please follow the officer into the jury room. We'll bring you back as quickly as we can. Thank you. Ms. Simmons, who's the next witness for the defense, and timing? How long do you anticipate the testimony to be?
Judge, I think the next witness will be fairly lengthy, maybe at least an hour with, I don't know how long the state's cross-examination would be, but given the last two witnesses, I think he would be at least another hour, probably more. His flight is tomorrow, so he's available in the morning. We have him and a fairly short witness tomorrow morning. And our last witness would be Dr. McLean, who's the one that has the issue that we discussed to try to have her testify on Monday morning.
Okay, so nothing's changed. You're not saying Dr. McLean is going to testify tomorrow, right?
No.
Okay.
I just want to make sure that we're
Right. Okay.
still.
So you have two witnesses. If this witness doesn't testify today, testify tomorrow?
Correct.
And that's, except for Dr. McLean, that's the last?
Yes, I mean, we would have a conversation with Mr. Nelson.
Okay.
But that's the extent of our presentation.
Okay.
Judge, again, for planning purposes, if we have Mr. Gravatt tomorrow, and who would the other witness be? Or is there another witness for tomorrow?
I thought I heard a mention of one other person.
Yes, Peacock, we have brief witness.
Okay.
He's Joseph?
Okay. Well, I don't know what the jury's plan. What I'd like to do is, if the jury's willing to stay, I want to get input from the jury as far as how they're feeling today, if they want to hear some more testimony today, since we have the witness here. So, any objection to me asking the officer if we would stop at 6, but we could at least get some testimony out until 6?
Judge, I think we would prefer to do all of Gravatt at once. And since we only have a quick 10-minute witness, other than him, I feel like it makes more sense to have him come back in the morning or before morning when they're rested, rather than just come in for a 10-minute witness or part of Gravatt,
Oh, I'm sorry, the other witness is 10 minutes?
right? I mean.
Yes, Judge, the last non-expert witness, Joseph
Right.
Pico, has very limited information. It's about a short period of time. I can't imagine that it's going to be more than 10 or 15 minutes. So I think what Ms. Simmons is saying is.
No, Mr. Nunnally, do you agree with that rough assessment of the other witness? 10, 15 minutes? 20?
Probably.
Okay, and do you agree with the roughly 1 hour for, who's the next witness?
Mr. Gravatt.
Mr. Gravatt? Roughly?
Roughly, yeah, I think so, yes.
Okay. Does the state have any objection to recessing today?
Leave it to the court.
Okay. All right, Ms. Simmons, is the defense ready to bring in the jury? All right, Mr. Nelson?
Yes, Your Honor.
Mr. Nunnally?
Yes, Judge.
All right, please bring him in. Ms. Simmons, does the defense acknowledge the jury?
Yes, Your Honor.
Mr. Nelson?
Yes, Your Honor.
Mr. Nunnally, state?
Yes, Your Honor.
All right, members of the jury, in just a moment, we're going to take our recess for the day. We'll plan to continue the presentation of the evidence tomorrow at 9 a.m., so just follow the officer's instructions as to where you need to be. Again, you are going to continue to leave your notepads and your pens here. And again, you remain under all the court's instructions, including but not limited to the instruction not to discuss this case amongst yourselves with anyone else, and not to read about news reports or in any way investigate anything related to this case whatsoever. Thank you for your service here today. Enjoy the rest of your evening. We'll see you tomorrow at 9 o'clock. Ms. Simmons, anything from the defense before we go into recess? Mr. Nelson?
No, sir.
Mr. Nunley, State?
No, Judge.
All right, we'll be in recess till 9 o'clock tomorrow morning. Y'all have a good evening. A bottle of water that you provided for your witness.